Hi, it's Jeanette Kingsley, and I'm going to give you guys a class on pregnancy-induced hypertension. Hypertension is the same as high blood pressure. It is abnormal systemic vasoconstriction. Hypertension is defined as systolic blood pressure greater than 140 millimeters of mercury or diastolic blood pressure greater than 90 millimeters of mercury. Chronic hypertension is defined as hypertension that is present before pregnancy or develops before 20 weeks of gestation. Women who have hypertension prior to 20 weeks of pregnancy are more susceptible to acquiring preeclampsia or eclampsia. Hypertensive disorders contribute significantly to maternal and infant morbidity and mortality. These disorders include placental abruption, respiratory distress syndrome, cerebral hemorrhage, hepatic or renal failure, disseminated intravascular coagulation, pulmonary edema, seizures, and intrauterine growth restriction. Pregnancy-related hypertension accounts for 10 to 15% of maternal deaths worldwide and is the second leading cause of maternal mortality in the United States. Pregnancy-induced hypertension, also called gestational hypertension, is the onset of hypertension without the presence of proteinuria after 20 weeks of pregnancy. Women with gestational hypertension have no evidence of pre-existing hypertension, and their blood pressures return to normal levels within 6 weeks of delivery. Although gestational hypertension can occur at any time after 20 weeks of pregnancy, it usually develops at or after 37 weeks gestation. Gestational hypertension can be classified as mild and severe. Women with mild hypertension usually have good pregnancy outcomes, while others will go into preeclampsia as they develop proteinuria. Gestational hypertension is the most frequent cause hypertension during pregnancy, with an incidence of 6 to 17% in first pregnancy. It also occurs more frequently in women with multifetal pregnancies, ages younger than 19 and older than 40, obesity, and pre-existing medical or genetic conditions such as chronic hypertension, renal disease, type 1 diabetes, and collagen disease. The cause for preeclampsia is unknown. The current thought is that the pathological changes that occur in a woman with preeclampsia are caused by disruptions in placental perfusion and endothelial cell dysfunction. So let me explain how that works. In women with preeclampsia, this vascular remodeling does not occur or only partially develops, causing decreased placental perfusion and hypoxia. Placental ischemia is thought to cause endothelial cell dysfunction by stimulating the release of substance that is toxic to the endothelial cells. This abnormality causes generalized vasospasms, which results in poor tissue perfusion in all organ systems, increased peripheral resistance and blood pressure, and increased endothelial cell permeability, making the vessels leaky and allowing protein to escape. This leads to protein in the urine, also called proteinuria. And as protein leaves the blood vessels, water also follows into the tissues, resulting in swelling throughout the body. This type of edema is found in the hands and the face and is defined as abnormal edema in pregnancy. Further, intravascular protein and fluid loss ultimately leads to loss of plasma volume, causing poor perfusion, resulting in increased blood pressure. Accurate measurement of blood pressure is essential in the early detection of hypertensive disorders. Edema is assessed for distribution, degree, and pitting. Dependent edema is edema on the lowest parts of the body like the feet and the legs, and this is normal in pregnancy. However, independent edema of the hands and the face is considered abnormal. Physical assessment. You're going to assess the deep tendon reflexes because they reflect the balance between the cerebral cortex and the spinal cord. And you're going to look for hyperflexia, that is +3 or +4. You're going to go ahead and listen to the heart and the lungs for adventitious sounds, listening for fluid overload. Neurological assessment are conducted, and that includes EOMs to test for nystagmus, PERLA, and assess for clonus. A very irritated CNS becomes apparent after +4 deep tendon reflexes. Eclampsia. If the patient has preeclampsia, she may become eclamptic. Eclampsia is the onset of seizure activity or coma in a woman with preeclampsia. Eclampsia, signs and symptoms include persistent headache, blurred vision, severe epigastric or right upper quadrant abdominal pain, and altered mental status. However, convulsions can appear suddenly and without warning in seemingly stable women with only minimal BP elevations. Nursing actions during convulsions are directed towards ensuring the patient has a patent airway and is safe. So you're going to look at your ABCs, airway, breathing, and circulation. You're going to note the time of the onset and the duration of the seizure. Immediate care includes calling for help but not leaving the bedside, making sure that the side rails are up and the patient is on bed rest. Darkening the environment to reduce stimuli is really helpful. And at this point, you're going to go ahead and start magnesium sulfate therapy, as it is a preferred treatment for seizure activity. Antihypertensive medications can also be administered, and rapid assessment of the uterine activity is important. Magnesium sulfate is a drug of choice in the prevention and treatment of seizure activities caused by severe preeclampsia or eclampsia, as it relaxes the central nervous system. It is administered intravenously. Initial loading dose of 4 to 6 grams is infused over 15 to 30 minutes. Mag sulfate relaxes the smooth muscles, so vital signs should be done at least every 15 to 30 minutes. In case of magnesium toxicity, you're going to watch for respiratory depression, decreased urine output, hypotension, hypoflexia, and sudden decrease in the fetal heart rate. Again, since it relaxes the central nervous system, patients may become comatose. And if this occurs, the first step in the nursing intervention is to stop the mag sulfate and give the antidote calcium gluconate as PRN protocol. So the only cure for preeclampsia is delivery of the baby in the placenta. Reduce physical activity, but not strict bed rest, and taking high blood pressure medication can lower the blood pressure, but it will not stop preeclampsia from worsening or reduce the risk of complications. And that concludes my presentation. Thank you for listening.